What's up, everybody? Dr. Rossi, StrengsandSneakers.com. So I've been on a kick lately covering these partial agonist medications, and I got another one for you that I think is important for you to know about, whether you're taking the medication or prescribing it, and that is Cariprazine or Vraylar. So this is a D3 partial agonist for bipolar disorder and schizophrenia. What I love about this medication is that it's approved for bipolar depression, and one of the hardest disorders I treat on a regular basis is bipolar depression, and there's not many medications FDA approved for that purpose. So Cariprazine, Vraylar, a good option here, and we're going to talk about what makes this medication a little bit different. We're going to go over the side effects, the dosing, and some of the indications for its use. So let's crack right into the video. The first thing to know about any medication is what are its approvals and what is it indicated for. So Cariprazine or Vraylar is approved for the treatment of schizophrenia. It's approved for mania associated with bipolar disorder. And the most important one, in my opinion, is the depressive episodes associated with bipolar 1 disorder. So depression and bipolar 1, because you don't have access to antidepressant medications, it can be mood destabilizing. My personal opinion on it is that medications like serotonin reuptake inhibitors are always mood destabilizing, and they often lead to what we call mixed episodes where there's depression and mania combined. So you want to watch out for those situations, and you want to avoid those medications if you can. But that leaves us with a problem. If I start someone on a mood stabilizer and they're still depressed, what am I going to do? What medication can I potentially adjunct with to treat that depressive component that's not going to make the person's mood less stable or unstable, right? So let's go into the pharmacology to kind of explain why this mechanism is different and what makes it kind of interesting as a potential new target. So pharmacology and mechanism of action. Most of these so-called atypical dopamine blocking medications are what we call D2 blockers. So they block D2 dopamine receptors primarily. And then on top of that, they also are what we call serotonin 5-HT2A receptor blockers. So if you look at all these medications' mechanism of action, one of the things you'll find in common with pretty much all of these atypical dopamine blocking medications is that they're going to target D2 receptors, they're going to block them, and they're going to block 5-HT2A receptors. So these are the two that are common amongst all these medications. What makes Cariprazine different here is the fact that it's actually a partial agonist at D2 and D3. So again, that D3 activity becomes important. And what makes Cariprazine different than brexpiprazole, which I talked about in a previous video, is that it has a high affinity for D3. It actually has a higher affinity for these D3 receptors than it does for D2. So it's interesting. Most people, like I said, most of these medications in the past have had high affinity for D2, not D3. So we're starting to see the evidence to support the blockade or activity at D3 being very important in bipolar disorder and schizophrenia. It's the same general concept that I've described for you with aripiprazole or brexpiprazole. It's pretty much the same thing, right? And I said to you that it will inhibit dopamine activity or act as a blocker in states of excess dopamine, and that it will act as a stimulator or stimulate these dopamine D2, D3 receptors in low dopamine states. So partial agonists have the ability to act as blockers or stimulators depending on the circumstances and the activity in the individual patient. Where it differs here is affinity for D3. I said that the receptors, the D3 receptors have a different location in the brain, so we'll talk about that briefly. So D3 receptors are located primarily in the ventral striatum, and this is important because that leads to less risk for side effects. One of the big deals with all these psychiatric medications and why people often stop them is because they cause side effects that are not tolerable, ones people can't deal with. So there's less risk for side effects, specifically things like EPS, compared to blocking dopamine receptors that are in the dorsal striatum. So this is a little technical, maybe beyond the scope of what most people need to know who are not physicians, but the idea behind it is that the D3 receptors are located in a different part of the brain, and they're located in a part of the brain that is less likely to cause your classic side effects from these type of medications. The other important mechanism of action is it's a partial agonist at 5-HT1A, and that shares a commonality with things like aripiprazole as well. When we're thinking here about the dosing of this medication, what's nice about this medication as well is it's once daily dosing. I always say to my patients, it's very hard to remember to take a medication 2 or 3 times a day. So any medication that's offered as once daily dosing is great in my opinion. And also the doses are much lower than what you would typically see in other medications. And that's because it has more specificity and potency at the necessary receptors. So schizophrenia, we see 1.5 milligrams up to a maximum dose of 6 milligrams once per day. So you start low, go slow is usually a good idea unless the person's in a very acute state of psychosis where they need a higher dose in order to get better quickly because they're doing something dangerous that could harm themselves or someone else. But schizophrenia, 1.5 milligrams to 6 milligrams. Bipolar mania is going to be 3 to 6 milligrams once daily. And bipolar depression, as noted before with adjunctive therapy for aripiprazole or brexpiprazole, you see that the doses are generally lower for depression and depressive states. So in bipolar depression, it's 1.5 to 3 milligrams once daily. This medication has a very long half-life, which can be a good thing or a bad thing depending on the circumstances. A very long half-life means that if I miss a dose or forget to take my medication one day, it's probably not going to be an issue. But the issue is if the person does indeed develop side effects from the medication, those side effects are likely to stick around longer because it takes the body longer to clear the medication out of the system. This medication can be taken with or without food, does not matter. And the notable side effects are going to be very, very similar to aripiprazole and brexpiprazole, which I described in more detail in those videos, but I'll point out the ones that I think are most important here, and that is akathisia, the risk for extrapyramidal symptoms, and restlessness or activating symptoms. That would be restlessness, anxiety. Some people develop GI distress on this medication. It can cause sedation and potentially weight gain, although not common. And of course, there's risk for the worst case scenario being tardive dyskinesia. But again, these medications have a much, much lower risk of things like tardive dyskinesia than the older medications we previously prescribed. So those are some of the notable side effects. Again, similar problem with all these partial agonists. They all seem to cause a lot of akathisia, and they all seem to cause a lot of restlessness and anxiety or activating symptoms in these cases. With that said, I'm going to cut the video there. If you guys have questions or comments about Cariprazine, I'm happy to answer them. Please drop them in the comments section below, and please like and subscribe to the channel for more content.